Dandy-Walker variants occur when there's absence or hypoplasia of the cerebellar vermis. Remember that vermian development is incomplete until at least 18 weeks. And when mistakes are made with the diagnosis of Dandy-Walker variant, it's often because the fetus is too young, the cerebellar vermis has not completely formed, and what needs to be done is a follow-up exam in 2 to 3 weeks and give that vermis a chance to show up. Another reason why Dandy-Walker variant can be overcalled is if the images are too oblique or obtained in a semi-coronal plane. If the posterior fossa is imaged in a coronal plane, you can take a picture underneath the vermis and make a suggestion of a Dandy-Walker variant. So if there's a question of a Dandy-Walker variant, it's important to confirm that you're in an axial plane and then to go on a search for the fourth ventricle and the vermis. Here's an example of a patient who was felt to have a Dandy-Walker variant. Here's the posterior fossa here and the cerebellar hemisphere here, and then the fourth ventricle, which appears to open posteriorly into the cisterna magna. But if you notice, the calvarium in this instance is incomplete. It stops right about here, and we don't pick it up till the other side. And that's our clue that this image was taken in a coronal fashion. And if the probe was tipped so that the calvarium is intact along the back of the posterior fossa, we see, as we do on this image here, that there is indeed a vermis and a distinct fourth ventricle, just in a different spot than was being imaged on the first image. Here's an example of a patient with a true Dandy-Walker variant. The fourth ventricle here is wide open into the cisterna magna, and the cerebellar hemispheres are flattened and distorted, particularly on the superior aspect of this patient with a true Dandy-Walker variant. Megacisterna magna is often overcalled as pathology. When the cisterna magna appears prominent, it's important to look at the underlying anatomy of the posterior fossa and identify a well-formed cerebellum, vermis, and fourth ventricle. Again, remember, these need to be imaged in the axial plane. There are normal septi that run through the back of the cisterna magna, and those can be identified and should not be mistaken for a cyst. And again, when the cisterna magna appears large, do a careful search of the brain for other malformations. If it's an isolated finding, the likelihood that there will be a good outcome in the fetus. Here's a megacisterna magna here, a large amount of fluid in the posterior fossa cisterna magna region. Notice the little crossing septations here and here. The measurement is 11 millimeters, but we have a well-formed cerebellum and a midline vermis. Moving on to mistakes that can occur in the face. Remember that when you're imaging the face, we need two different images. I need an image of the nose and lips, looking at the superficial soft tissue of the lips and outlines of the nostrils. And don't forget to image the orbits. There has to be 2 orbits in every fetus to call the face a normal face. Here's a really cute picture of a fetus. The parents were delighted. It's, I show it multiple times. Doesn't it look great? You can see the eyes and the cheek, and it's an adorable picture. Is it normal? Well, you can't call the face normal because you do not see the soft tissues of the nose and lips. Here's the image of the nose and lips. You can see the lower lip here and the upper lip, and there's a cleft indeed coming from the right nostril down into the upper portion of the mouth. So make sure that to call a face normal, that soft tissue plane of the upper lip is seen in completion. Here's another patient who was brought to my attention because of the possibility of a cleft lip, and here's the upper lip right here. The rest of the face would be here, and there is a cleft or a vague cleft right in the midline, sort of obliquely there. But if we scan a little bit more posteriorly, we can see that actually the lip is completely intact when I have the nose on the image, and this is just a prominent philtrum, or that cleft in the soft tissue in the upper lip. And it can be confirmed, if possible, with 3D imaging. Here's an image of the fetal face, and we can see that the upper lip is completely intact. What do I mean by orbits? I want to see 2 bony orbits. Here and here, they should be symmetrical in the head. It's not enough to just see the top orbit. Both of them need to be identified. Here's an image of the orbit in a patient. This is why we're looking at the orbit, because in this instance, the 2 orbits and the nose, there's a big soft tissue mass here protruding from the anterior aspect of the nose between the 2 orbits. And here it is seen on the more sagittal plane, And you can see that the tissue here is identical in echo texture to the tissue of the brain, and this is an extra cerebral glioma. Another structure that can be identified on fetal ultrasound in the region of the orbits is this structure right here, a little round, anechoic, spherical-shaped structure with through transmission possibly identified right in the region of the orbits. And on this axial image of the lower portion of the orbits here and here, we can see the little tiny black circle. And this is a dacrocystocele. This is a blocked lacrimal duct, and the tears back up into a little bubble of fluid. It has no clinical consequence and will disappear after the baby is born, should not be considered to be pathology. Here's another patient, again, looking for the orbits. This is the axial view of the head, and this is the region of the orbits, but we do not have the well-defined bony structure of the orbits on either side, and the nose is very flattened. And on this profile view of the fetus, you can see the chin and the lips, and notice that the nose is completely absent in this fetus. And here's the 3D image. You can see a prominent forehead and just collapsed soft tissue areas where the orbits should be, and no visible nose. And indeed, this child was delivered at term with no nose and no orbits. A few words about mistakes that can occur in the kidneys. The kidneys in particular can be very challenging on the 18-week survey, and a typical mistake that happens is that the adrenal glands are identified and labeled as kidneys rather than the kidneys themselves. And your clue that you could be looking at the adrenal glands is if the stomach is on the image, because the stomach is typically higher than the level of the kidneys. Another clue, adrenal glands are very prominent and very hypoechoic, and they're easy to see. The kidneys are isoechoic. They're very difficult to see. They can be quite subtle at 18 weeks. If you're lucky, there'll be a midline black slit or a little bit of fluid in the renal pelvis that will help you confirm that you're looking at kidneys. So here's an example of a patient shown to show you at 18 weeks. This is reported as kidneys, but we're at the level of the stomach, and here's the hypoechoic on the left, hypoechoic area on the right. These are the adrenal glands. And this image, taken much lower down with no stomach on the image, is the kidneys. Here's a kidney here and a kidney here. And indeed, they're very subtle. They're hard to see at 18 weeks. Here's a clip going from the pelvis up through the abdomen, starting at the bottom, down by the bladder, and again, the kidneys here and the adrenal above. Here's a patient who was seen at 18.5 weeks with a normal kidneys reported, and this is the image that came out labeled kidneys. And here's the stomach here, and we can see a probable kidney on the right here, but there's nothing convincing on the left. There's a little hypoechoic structure here, but this is too high to be in the region where a left kidney should be because we have the stomach right there. And indeed, when this patient returned at 30 weeks, again, here's the right kidney, aorta IVC, stomach bubble, and a little hypoechoic area here, but no definite kidney seen in the left renal fossa. Sagittal images of each kidney were performed. Here's the right kidney, 32 millimeters, right where it belongs, under the diaphragm. But on the left kidney, we see the lying down adrenal sign, where the adrenal is elongated and stretched along the spine because there is no kidney in the left renal fossa. Okay, so there's no kidney in the left renal fossa. We don't stop there. We need to go looking for it, because sometimes it's not missing, it's just in a different spot. And down in the pelvis, we can see posterior to the bladder, here's the left kidney, and this fetus has a left pelvic kidney, which was missed at the 18-week scan.